we're going to get started. We may be seeing still several people come in because I heard that some of our MBA students are just finishing up, so you may see them coming in. But yeah, so thank you so much for being here and for joining us on our first ever health sectors leaders consortium here. I'm Pınar Karacamandic. I'm a professor at the Carlson School of Management in the Finance Department. I'm a health economist, and I'm the founding director of our Business Advancement Center for Health, and we call it BACH, like the musician. And I have to credit Kim Choik, whom you have interacted. Kim is our program manager. Kim gave the name to the center, so thank you, Kim. I'm so happy to be back on campus also and hosting this hybrid event. And to those of you here in person, we're thrilled to see you and meet you in person, and we look forward to connecting even more during our networking session at the end of the event. And for those of you joining online, I know the audience here can't see them, but we have a lot of participants online. Welcome, and we would love to see your faces as well. But hopefully next time, in the next event, we'll be able to meet you. You're welcome to submit your questions through the Zoom chat. Or Kim, are they able to unmute and ask questions?
The chat will be the easiest.
Chat will be the easiest. One of us will be monitoring the chat, so we'll be able to get your questions during our Q&A. So this is BACH's first event of the academic year, and we launched BACH at the Carlson School this past January. And as its founding director, I'm really honored to lead this exciting new research and outreach center as we reimagine health and healthcare together with the community and the stakeholders. Our vision is through designing and evaluating the next generation business models. We want to innovate on evidence-based and data-driven sustainable, which is really important, sustainable solutions to effectively address some of the critical gaps that we have in our healthcare system, in particular with regards to healthcare costs, quality, and access. Our mission, if I were to summarize it very in a simple terms, it's to improve value and equity in health. We're going to grow with BACH Carlson School's expertise and focus and partnership in the healthcare community as a thought leader and convener to tackle some of the critical issues in healthcare. And we're looking forward to hosting a variety of events this year, including our 4th annual University of Minnesota Interdisciplinary Health Data Competition and our 5th annual Convene Conference later this spring. So stay tuned for more information about that. And that said, I encourage you to also follow BACH on social media and to stay engaged with us and be up to date with some of the events that we're doing. This summer, we were very busy expanding our outreach and community partnership to develop some impactful research opportunities and events. If you look at our website, you can see a little bit of a sample of the type of work we do. We are very fortunate to be located in this very thriving medical ecosystem of the Twin Cities, and where we can bring together leaders like you, our students, our professionals to share some of the unique perspectives they have on trends, opportunities, and challenges in all sectors of healthcare. And needless to say, as we transform from this pandemic into the new normal, this thinking about and rethinking some of the things we've been doing is super important. In order to be innovative, it takes us coming together, providers, payers, medical technology, policymaker, researchers, the healthcare consumer at the center to support some of the new ideas, to generate new models of business, new technologies, and their implementation into our healthcare system. So we hope that you will take this information from this session and apply it in your work, whether it's research, your teaching, your school projects, or professional work, and with the goal to really lead innovation and change and use it as a business, use business as a force for good, which is what we live by at the Carlson School. So before I introduce our first presenter, I need to thank each one of you here in the audience for joining us. And the presentations will be recorded, so you'll be able to see them on BACH's website later on. I would like to recognize our event sponsor, presenting sponsor, United Health Foundation. The event would not be possible without them. And also a big thank you to our planning team, Carlson School Executive in Residence, Gopal Khanna, BACH Program Manager, Kim Choik, and MBA students, Nathan Jones, and Nida Yamin, who will join us shortly as well. So finally, thank you to our speakers. I know there's some other, I see Frank over there too. We are really honored that you joined us today, and bringing together such engaging, innovative group of leaders means a lot to us and our community here, so thank you so much. With that, I will introduce our first speaker, Andy McMahon. Andy, I don't know if you wanted to come here. Andy McMahon is the Vice President of Community Investment and Innovation at UnitedHealthcare Community and State, who proudly serves more than 7 million Medicaid members in 31 states and Washington, D.C. And he works on community investment and engagement efforts to build and expand community partnerships. And he works closely with the United Health Group Treasury to expand and diversify the ways they invest to support communities across the country. And he drives innovations at the community level, including the UHC Catalyst Initiative and other new endeavors to address social isolation. And he partners with the community and state policy and influence team to advance an array of policy priorities. Prior to joining UnitedHealthcare, Andy worked at the Corporation for Supportive Housing, CSH, for 15 years, most recently as the Vice President for Policy and External Affairs. So thank you, Andy.
All right, thank you.
Will you be using the view?
I'll just stand here. I'll be good, thank you.
Thanks.
Thank you so much for the introduction, and good afternoon. How are y'all doing today? It's summer before it's going to be winter, right? So no complaining about the heat, people, if you live here. So thanks again. Andy McMahon, Vice President for Community Investment and Innovation at UnitedHealthcare. Really delighted to be here with you all today to share a bit both about our UnitedHealthcare Catalyst model and our Communities of Health model. And before I take you through this, I should say, because when we set out to create our Catalyst model and now our Communities of Health, it was literally trying to say we need to work with our health plans to flip on its head how we operate and how we approach and engage with our communities and our community partners. And I was essentially brought in when I was hired. My boss literally told me my job was to agitate and disrupt. And coming from 20 plus years in nonprofit to a big corporation, I thought I might last about 2 weeks disrupting corporate America from my nonprofit lens. But I'm 5 years in and delighted to be here today. So, we set out about 1.5 years ago and launched our UnitedHealthcare initiative. It's really aimed at creating cross-sector partnerships among a host of agencies, which we'll talk about. But I think from where we sit, one of the things that we say in healthcare, there's a lot of things about competition that are good about healthcare. There's a heck of a lot of things that shouldn't be about competition, but should be about collaboration. And so that is kind of fundamentally what I would say. And what we do through our Catalyst model is based in that notion that if we work across sectors and across partners with other payers, with community-based organizations, that we can actually create better results for the community. And importantly, too, I would say for us in this model is that it is kind of, quote unquote, in my new healthcare land, payer agnostic, right? So our efforts around Community Catalysts are not targeted to UnitedHealthcare members at all. They are targeted for everyone in the community. By and large, very low-income people, but not. It's not intervention-based, focused in on our members. And our value proposition really is: if we can all work together, can we figure out how we can close gaps in care in the communities we serve and improve health outcomes at the individual level and the population health level? Before I'm going to walk through briefly kind of our approach to doing this, but I want to share with you guys one of the things that I hopefully nicely and politely, but also directly say to our health plan leaders, CEOs, and chief medical officers and the like, is that when we start talking about our Catalyst initiative, it is genuinely, when we go out into the community, eyes and ears open, mouths shut, right? So listen to the community, hear what it is the needs are that people in the community are saying are important. And that's where that first part comes in terms of identifying a community health issue to address. We certainly leverage, we have, pretty robust data and analytics, so we certainly leverage those analytics to understand where there might be hotspots in healthcare issues. But the decision on what we do will be based on what the members of the community say. And I will tell you, by and large, we've had pretty significant corroboration of kind of community need and data, but not always, right? And so we're saying, look, if this is the hotspot that you guys feel, that's where we're going to go. Collectively together. So we work together to identify a community health issue and then convene these partners. As you can see, our model involves community-based organizations, ourselves, the Federally Qualified Health Center, and other clinical partners, as well as public housing agencies. So we have 22 catalysts currently, and in 10 of them, we are also engaging with public housing agencies, particularly in states that expand to Medicaid. The overlap between people living in publicly assisted housing and people on or eligible for Medicaid or duals programs is 80 to 90 to 95%. So there's a huge opportunity to create those partners. But we work together with them and convene and set out and then collaborate and actually develop formal memorandums of understandings with our partners to say, here's the role that each of us are going to play, right? So we as a payer, we can provide these data and analytics, we can provide these clinical capabilities, we can do X, Y, or Z. Community-based partner, let's say we're working on food insecurity, you can think about SNAP and WIC enrollment and advocacy, you can think about where we have tie-ins with food banks, how can we tie in federally qualified health center clinics as access points for getting to people to other services and supports they need. So really trying to create that collaboration and then act, right? And saying that we're going to we've set out this plan and we're going to now execute on that and we're going to measure the results we have from it. I think two things that I would say, so there's a whole host to our, of kind of elements to our catalyst. I think if you take away any two things, hopefully not one, if you could take away two things from our catalyst model, I hope it would be one, shared decision-making, right? So it isn't UnitedHealthcare coming in and say, we identified this problem, we're going to pay you X to do Y, right? That's standard business, basically, in managed care. We're not saying that. We are listening to the community and saying, okay, here's what are you seeing, what are we seeing, what are other people seeing, and then coming to a decision on issue or issues to address in the community. And then the second important thing I hope you remember is co-creation of interventions to address the issue. Right, so we're not saying, okay, well, we now have the capability to solve this, or, FQHC, you're an expert at that, you fix that. It's all of the groups coming together and saying, okay, what is the role that I can play, right? What are the capabilities and resources that my entity can bring to the table? And I'll tell you guys, I mean, it hasn't been easy for some of us, right? Because it's a different way of doing business, right? It's hopefully is disruptive and changing it. And so, so we're learning ourselves, right? We've been at this for a while, but we put a lot of energy and resources to it in order to pull this off. This just gives you a sense of kind of how we view the achievement of getting to outcomes, right? It's similar to the last in some ways, but importantly, I would say talking about that measuring and refinement, right? Whatever we decide as a community, we're probably not going to get an A+ the first time out, right? We're probably going to be things that we're going to refine and say, geez, Andy, I can't believe you didn't realize that this partner needed to be at the table. Or Andy, I can't believe you and your team missed that this was something that needed to happen or needed to track. And so we will be very robust and rigorous in how we are tracking outcomes. And then importantly, right, I always tell people on my team, it's like, not only track the outcomes, behave differently because of what you learned about the outcomes, right? If you're crushing it, great, keep on going. Odds are you have room for improvement, right? And so what are those areas? And then actually refining and changing your process so you actually do that. Whoops. I'm going to mention real quickly, and then I will stop. And I don't know if I have a couple minutes maybe or not or later, but I wanted to try to leave time, so I'm going quick. I'm also kind of proud to say that across the river, albeit, but in St. Paul, we are launching our Communities of Health initiative, which is in many, many respects the same and similar to Catalyst, but we are also bringing together large employers and bringing them to the table to address problems, right, where a lot of their employees live in these communities, right? And so And we're saying, and honestly, in some cases, we may be the insurance provider for some of these big ones, and we're saying, you guys should get in and help these communities that your staff people are coming from. And so we have partnered really closely and worked with Fairview Health System, Minnesota Care, Second Harvest Heartland, and others, and with the kind of reimagining and the Health and Wellness Center that they just launched, I guess, a few weeks ago now in St. Paul. So we are proud kind of in investors and supporters and partners with them. And now we'll be thinking about, I'm not going to name any names, but talking about some employers and saying, okay, you have a lot of employees here. Why don't you put some skin in the game? And I will tell you guys, from where I sit, it's really in two ways. One is, for sure, do we want you to make a financial investment in this? Sure we do. Of course we do. We also want you to bring your capabilities and your resources, right? So if you're an entity, and I won't name any, but you can think of a lot of employers in the Twin Cities area that not only have cash, they have capabilities and resources and networks that we can and should be leveraging. And so we're trying to think about, what is that and how do we kind of make that case to employers. And I'm happy to say that the case I try to make is hopefully, people should watch us, but we are walking the walk, I can tell you, because we are investing over 3 years. We're making investments in these communities. But I will honestly tell you, our bigger, more important investment will be clinical strategies that we bring to the table, networks that we bring to the table, other capabilities that we bring to the table. It could be some of our treasury impact investing work that we make larger investments in some of these efforts. And so, I think from my perspective and from our perspective at UnitedHealthcare, and I'll close with this, right, is that, I always tell people, if we were to bubble it down to 2 words, I would tell you better together, right? So as we go off and do all sorts of things as UnitedHealthcare, and we're as guilty as anyone, so that's what I'm changing and working to change at UnitedHealthcare, but, we're often, most of us, off doing our things, and they are great things, right? And people should be proud of the things they're doing. I think, my philosophy and our philosophy is that we could be more impactful and be even doing better things at greater scale if we are intentional and collaborate and work together. So with that, I really appreciate your guys' time and look forward to any questions now and the reception as well. So thank you all so much.
We do have some time for questions.
Yes, sir.
So where does your initial population health data come from that you look at and you analyze and say this is where we're going to target at the beginning of a project? Yep. So yes, what sort of population health data are we looking at the outset? So we are looking at a lot of community health needs assessments by hospitals, by counties here in Minnesota and elsewhere. So I think we are looking heavily at that, I think, and then also looking at depending on the community, our own data and analytics. I think we largely feel like, especially when you have an N of, 10, 20, 50, 100,000, that at least when we think about Medicaid, that if we have that general thing across 50,000 people on Medicaid, the likelihood that other health plans that have another 50,000 on Medicaid, there's no real reason to think that theirs is going to be dramatically different. And so, I think we lean on kind of some of the amazing work that counties and hospitals do in their assessment work, and then bring whatever other additional analytics we can bring to the table.
Is there another question over here? You can just use the microphone. Thank you.
Thank you. So I have a question. You spoke about, in this model here, about measure and refine and that how you are doing rigorous tracking of outcomes. So my question is twofold. One is, first of all, how do you begin to engage in those partnerships across different organizations? And second, when you are trying to measure and refine a solution, these are multi-organization solutions. So how is the change moved through those organizations?
Sure. When it was on the mic, so we're good. So yeah, great question. And the second one's tough for sure. So on the first, I would tell you when we think about initial kind of partner engagement, I think one of the things that we often look for is kind of shared interest, right? And so I'll tell you, the public housing agencies are a great example. You could first talk to them and you could be like, they'd be like, why do you want me, like I have enough trouble running my public housing agency and my 10,000 units of affordable housing. Like why in the world do you want me engaged in this food security initiative or this maternal health initiative, right? And so we use data a lot to then leverage and say, okay, well, we did a cross match of data and 83% of your members are on Medicaid. And of that percentage of the people that we see that 21% of them are food insecure. So you should care about this issue. And so I think we really look to ensure, right? Because if you're going to, at least in my experience, and this isn't just in managed care, in my whole career, right? If you're going to have meaningful collaboration, it has to align with what that organization's really trying to achieve, right? If they're doing it as a one-off and they're like a favor to you, it's not going to be much of a favor because they're not going to spend much time on it, if it's not core to what they're doing. So I think we really look for that mission alignment, but then also trying to say, how do we get to that kind of shared win, right? So we're working to address food insecurity. It might be that the clinic this happens all the time, by the way, I'm not making it up. The clinic 2 blocks away is like, yeah, we're serving all these people in the behavioral health clinic, but we also realize a bunch of them are always asking us, well, how do you get to the food bank? That same person is a public housing agency resident, right? So they just kind of touch the system at different places, but a lot of them, there's a commonality about it. So that's one. On the measuring and refinement, so we're about 1.5 years in, and we're doing now some of the interventions. So I'll be candid, we haven't gotten to final measurement and revisions yet. I will tell you, in thinking about how we approach it in other ways, one, I think, from where we sit, we try to honestly limit the number of things that we're going to track and track those things well. Sometimes people say, well, I want to track these 9 things. Unless you're really, really, really good at it, you're probably not going to track 10 things real well. And so we try to think about what are 2 or 3 key metrics that we feel like we can track credibly, right? So that when we get there and we say at year 3, this is what happened, that we have a pretty high level of confidence that that's true, right? Because there's a lot of times people do things, and if you do it sloppy, I've done it sloppy in my past, and you say, oh, here's what we found. It's like, you might be wrong, actually, because I didn't do it well enough, and so you can actually be misguided in what you're doing. So I think we're trying to be really concrete and concise in terms of the things that we're measuring. And then I think, we've used a number of different kind of logic models and other things to think about what's impacting what. So if we see this change, what is it that created that change? What is the lever? What are the 1 or 2, 3 levers that are most impactful to that change? And then looking in at those interventions, those strategies, and then refining those.
Andy, we do have one question from Bernard online, so maybe take another minute. So his question is, how are these community-based initiatives impacting disparities in healthcare among people of color? And what are examples of organizations that United has collaborated with in these communities?
Sure. So I think, great question. And I think, if you look at a lot of the communities where we have our Catalyst model, and if you Google it, or I can send out a link if we have it on the chat, I can get on the chat and do that too. But if you look at not only the communities that we're serving, but the parts of the communities that we're serving, I think you'll see heavy concentration of BIPOC communities and other communities that
honestly been divested in and not been supported. And we are looking and through data and analytics, looking at demographics and other things and targeting the communities that we are serving through there, and then trying to identify, community partners that have the cultural sensitivity and awareness around the care, right? Which is a huge thing, right? Culturally appropriate care and healthcare is massive. I'm sure my time is up, but if some of you probably will know about this, but if you think about white doctors taking care of black mothers versus black doctors taking care of black mothers, the discrepancy in the health outcomes is remarkable, right? Because you have kind of incongruent care, right? You have a doctor who really cannot really, doesn't, and so that impact is huge. I will say to the person online, we're working on that. That's a real big challenge, right? I'm not sitting here telling you we've figured that out, because we haven't. But I can tell you we are really focused hard on improving and progressing in our as we think about our network of providers and ensuring that they are providing culturally sensitive care. All right. Thank you all so much.
Thank you so much. Thank you, Andy. Our next speaker is Grady Davis. Grady, thank you for being here. Grady is the Vice President of Global Commercial Marketing for Structural Heart Business at Medtronic. Grady is responsible for pipeline priority, global commercialization, and TAVI market development. During his 15 years at Medtronic, Grady has developed and launched numerous marketing initiatives focused on healthcare, professional engagement, patient product pull-through, and value-based care. Thank you.
Thank you. Such a pleasure to be here. This is great to see, and I appreciate, Andy, what you're saying, and that there's a vulnerability we're all coming forward with that we haven't figured all these things out. So this is the fun part of we need partnership, we need this kind of counsel, and it's great to see this here. And I'll tell you, this is one of the favorite parts of my week. I've been looking forward to this, getting out of our day-to-day, what we do. I tried to fit every, kind of buzzword in business on this one here, was probably the intent. But in all seriousness, though, value, I know it's a core tenet here for the consortium. It's a real challenge. And how do you continue to focus on value and hold value, especially as you scale? We all start with little small ideas. They start to grow. You start small. Next thing you know, you're big. And how do you hold that value and focus as you scale? Two of those little buzzwords, from B school, I think are really important. They typically are mentioned as independent initiatives, centricity, intimacy, but I believe there's something to holding these two together. The intersectionality of these two is really critical to value. So I really want to explore that in this and take some questions on how we focus on this, why it's important, and then how we do it. I want to give you some real examples of some things that we've tried at Medtronic and what we've done to hold this. First, starting with this here, the animation changed a little bit. I think the first thing is just definition. There's a lot of different definitions, a lot of the initiatives around these two. But centricity, I think it's pretty simple, keeping your customer center to what you do. When you think about it, very much like you idolize an athlete or someone who's famous, you kind of know a lot of things about that person. So when you think of that centricity, it's really how do I get in the mind of that customer, stay grounded, stay focused what they do, learn their habits, learn things about them. Intimacy, it's interesting when you're looking at the definition there, it's not just, knowing the customer, really staying close, but it's a lot around saying, will I change what I'm offering for that customer? So, hey, keep you central, but also am I willing to change what I'm doing based on your needs and what's out there? So two, just to ground us on the definition. Like I mentioned, holding these two, I believe there's a lot of value. Our challenges, frankly, as we scale, what happens, right? We get, complexity, policies, we get employees, multiple stakeholders, boards, you name it, right? They're all pulling us, and that's taking you in the opposite direction of holding that value, holding that centricity, holding that intimacy. A good case example, I believe, is Medtronic, hometown company, as many of you know. When you think back, back in the late 50s, when Earl Bakken was not too far from way here, the garage is not far, working with Dr. Lillehei, you had two people in a garage working on a solution, an unmet need for Dr. Lillehei, one customer, right? It was somewhat easier to do that. If you think about it, what they had was that ability to keep Dr. Lillehei's core, central to what they're doing. And I'm assuming everyone knows the story. Maybe I shouldn't. Does everybody know the Medtronic There's a lot of hands that didn't raise. But it's this amazing story. You know, two guys, garage not far from here, and a power grid. As we found in the winter, that is coming, unfortunately. And the winter comes through, the power grid would fluctuate. You'd lose power. The most sick patients, many of the children that were counting on, heart-lung machines, pacing machines to keep them alive. When that power went out, these patients could die. So Dr. Lillahei had asked Earl Bakken, who was working as a bioengineering tech in the hospital, can you build a battery power pacemaker to keep these patients from, frankly, dying? So you can imagine in that setting, real central. He knew, I got one customer I need to make happy. Intimacy was definitely there. He was actually trying different models, bringing it into hospital. Anyone in the regulatory space like FDA, that would drive him crazy today. But that's how close these things were. That's the origin story of Medtronic. But I do believe it really was that value that he was able to drive because of the centricity, because of the intimacy. And our challenge, as we've scaled quite a bit, two people in a garage have grown now to 90,000 employees, the world's largest medical device company, which is unbelievably impressive when you think of it. But our technologies have grown in breadth as well, too. So keeping hold and away from this challenge, this is what marketing and med tech does every single day. Balance these complexities to make sure that we stay really zeroed in on what truly is value. But let me give you an example, though. I know this is a little bit high level there, but how does that really play out? I'm geeking out here, thinking back to B school, but I mean, one of the most, I love just this portion of it. I was an engineer by training, so getting into B school was just I loved it. It was a lot of fun. What Dr. Levitt talked about, and our professor who talked us through this, it's a famous quote here about what patients really want. He really teased it out. He said, hey, I need to put a 1/4-inch hole in a board here. What do I need? Whole class is going all around. You need this kind of drill, 16 volt, 22. Is it metal? Is it wood? What do you need? All that. About 10, 15 minutes later, he said, no, future marketers, they need a 1/4-inch hole in the board. That's it. If they could do that, if your customer could do that without the drill, with all the other things you just talked about, they will skip that. They will disrupt that business to get to that value. And always, that stuck with me, and I remembered that. And in our spine business, challenge when I was in that business that we were dealing with was we were seeing a lot of, loss of pricing, commoditization started to come in. A lot of these challenges of like, wow, we're putting a lot of great innovation, but it doesn't seem to be rewarded. So this value canvas, the teams have discovered, we built an entire advisory board, bringing some of the smartest, if you look in that bottom right-hand corner there, these are some of the top spinal deformity surgeons in the world. We flew them in and said, we want to talk to you about value. Now, I can tell you, as upstream marketing leader, you've got a bunch of engineers in the room who are here asking you, but they want to ask, what thread pitch do you need? What type of screw? What kind of inner body do you need? And we said, no, let's zoom it out a little bit and see what's of value to you. And at first blush, this a lot of them felt it was a failure to have that advisory board. We spent an entire day digging in. Take preoperative, what do you need? Take intraoperative, what do you need? What's the most important job to do? What pain points can we help you solve? Initially, they thought that was a waste of time. Because they came back with, it had nothing to do with the screw pitch, the thread pitch, nothing to do with, the technologies we wanted to deliver. It said, you know what? Preoperative planning is critically important. Knowing which patients I need to take to the OR and which patients that I need to send to rehab. That's what's important to me. And they're saying, hey, clearing the inner body space. We get paid in that business on the hardware you leave behind, the screws, the inner bodies. They said, what's important is clearing the disc space. We have a really good fusion, a clinical outcome that they need to get. All things that, again, that we weren't necessarily zeroed in. But it was prophetic because that's exactly what was harming that space because we weren't zeroed in. Fast forward, a few years later, we're acquiring companies that focus on preoperative planning. We're acquiring companies that we're building our surgical sets and instrumentation, with the other parts of the procedure in mind, knowing that if we get that right, we help you do the most important jobs. The implant will follow through as you go. So it was a good learning for us and something that we've had to continuously keep focus on in order not to lose value. So kind of bring it in, and to the point here, and hopefully it resounds with you. We've got to focus on that. We've got to kind of remind ourselves here, these two pieces, where are they in your organization, in your functions, or in your businesses, and also reflect back on when you started. I mean, we spend a lot of time at Medtronic with the mission and going every talk that we start with our clinicians. We start with the mission, the Earl Bakken story, because it does kind of ground us back a little bit to say, two guys in a garage trying to come up with an idea for one customer, that's where the value really happens. So getting yourself back to that and get uncomfortable. Let me tell you, it was not comfortable in that room with a bunch of R&D folks looking at you like, that was, good job, Marker, that was a really good meeting. And then seeing it move forward, and we're like, oh my gosh, that they were telling us exactly what we needed, where the value was, we just had missed it, and we had to tell you, spend a lot of money to go back to acquire technologies to close those gaps. And we could have saw that, close to 7, 8 years earlier before. So thank you. It's time.
Do you have any questions?
So you talked about value-based care and what Medtronic is doing along those lines. So healthcare sector, we are here today because healthcare sector is a lot of diverse players with their own varied interests around. So what is Medtronic doing, or what should it do down the lane to ensure that all the sector players like payers, biotech, pharma, all the companies have this patient-centric approach?
Yeah, absolutely. I mean, and again, it's so strong to what we do. Our previous and current CEO, have committed to what, value-based healthcare looks like. And that's tough because we see two models running at one time. In some ways it's counterintuitive. The more things you do to a patient in a healthcare system today, the more you get reimbursed. So there's some anti-incentives that are there. So we've got to continue to, work in that model, work in that environment, but also push ourselves, into the new models. And we've done a lot. I can give you some examples. For example, risk sharing. These things that are, safe harbors from the DOJ, so aligning clinically, regulatory. But if we can go to a healthcare system or go to a payer and say, if things are happening the way we intend, we expect that you should see a return. A real example in one of our businesses that did is a cardiac heart failure. Sorry, the words escaped me. A heart failure business. It was a new way of doing a procedure. You can traditionally crack the chest open, long rehab, very sick patients, cost a lot of money, infections, readmissions, all those things. So we worked with some health centers to come in and say, what about a new thoracotomy approach, a more minimally invasive approach that we felt some of our technologies would actually facilitate better. Great, we actually quantified it and said, we believe this equals about $40,000 to $45,000 of cost savings. If we don't hit that, then we'll put our money where our mouth is and actually guarantee you, that reimbursement if you see those. So what I can tell you, I'm not saying we ran out and signed a bunch of those deals all across the industry, but the different seat we had at the table, just walking forward with that, saying that, this is how we want to partner and think with you. Look, did we know absolutely that will work? We're taking a lot of smart people, but we're willing to jump in and take that risk with you. That's a different conversation with the health system. It's a different conversation. You feel like a partner, a much more of a partner than just, transactional, a vendor, and that's where we're trying to move away. So some real example, it's not easy, we're still learning, but we're still willing to have those conversations and frankly push them into as many of our service lines as possible.
This is not directly a Medtronic related question, but following up, there's been talk about value-based care forever. Mm-hmm. However, the system depends upon fee for service. Mm-hmm. And realistically speaking, do you guys even see the possibility of value-based care really becoming a reality, or is it just something that gets talked about? CMS is trying to respond, they have different models of care. What do you see as the future?
Yeah, it is. Very similar last question. We have to play in both worlds very effectively. If we are extracting, I know the downsides that could happen. If we, I'd say we, meaning, the industry, if we simply extract value from the healthcare system, just taking it, the number of community hospitals you run into where they're, where maybe we're making a profit and they're barely making it, that can't sustain. Right? If they're losing money on a procedure in some instances, that can't sustain. So in the fee-for-service model, we have to continue to optimize and do things that are right to truly be partners. So we're there for the next, 70 years. We've got to do that. But we do have to look forward to disrupting. It is changing. Healthcare is becoming much more consumer. The guidelines are driving, more consumer input, more patient input in their decision making. That's happening. I've got a chance to go to some other industry conferences, and we always think we're so different in healthcare. And I went to a conference, Macy's was there, a few others throughout the retail space, And I thought we are regulated. Those that are in the financial services industry, it's 10 times worse there. But I think the consumerism of healthcare is real. And I think as that experience changes, I think people will demand that. I want to see the value. I'm not necessarily blinded, from that any longer. I think employers are going to play a big role as well too. That they're having a different conversation with health plans. And I always feel bad for the health plan because a lot of people forget your employer is making that decision and letting the payer kind of be the bad person there. But it's changing too as well as they have more transparent conversations with employees around, hey, this is what this care truly cost. Here is your financial stake in that. And it's driving a different decision, I think, from patients as well. So I think as patients start to come into that more, that's going to drive it. So we've got to, continue to maximize things in the fee-for-service world, but get ready. Last thing I'll say there is there are good examples around the world too. So we have committed, at least, one thing with Medtronic, we are completely global. Those 90,000 people all over. I just had some recent conversations in Turkey, for example, where the entire financial system is changing so much because of the currency fluctuations. So in situations like that, we've got to think different, invest different with the ministries of health, and work some solutions that can benefit patients and not just think of the fee-for-service model. So there's great examples across the globe where industry has partnered to do it. As that consumerism comes into healthcare, we have things that we can apply, provided we stay partners and work at the table. So I do think it's coming. We're still a ways away as that model changes, but like all things, right? It's exponential. We think it's going to be long, and next thing you know, it will be here. So we are ready for it.
We do have one question online from Ellie. So we have about a minute or so for this one. She says, excellent talk. Do you engage patients in trying to understand the value gap?
We do. And it's a very touchy space. I know we have some physicians in the room too. I mean, getting direct to patient is tough. I spent some time at Pfizer where it was, on the pharma side, a lot of direct to patient. We learned very clear there, the early pharma commercials did not work well at all. You had to what we call condition the healthcare community, talk with them first. Hey, these are going to go out, get ready, understand what's coming. Patients are, demanding a seat at the table. We are also seeing a lot of the big societies also put in the guidelines, patients should be consulted here. On major things, in the business I'm in now, it's aortic valve replacement. So that's one where you want to listen to your doctor on that decision. But even in the guidelines, it says, consult patient on what they want to do for surgery versus, a TAVR, a trans, more of a catheter-based procedure. So, yes, so the patients are part of that conversation. We have to continue to get better there, I will say. Not just think of it from that, kind of pharma model, let's go direct to consumer, buy this versus this. I think we've got to step back. So a lot of the approaches you see in many of the businesses, at least from Medtronic, are more the, I'd say the therapy awareness world. We spend a lot of time, an entire team that does just that. We call it market development, therapy awareness. The idea there is there's plenty of business out for all if we focus on the value of getting the treatment. Last example, sorry, I love stories. You look at it, I was in our diabetes business, and there's a point in time where the insulin pump, so people who have, dependent on type 1 diabetes, dependent on insulin, you can do the shots every day, or you can do a continuous infusion with an insulin pump. And there was a point in time where maybe 15, 16% of the market was the pump. Everything else was the injections. And all the data, all the evidence, no matter what pump you pick, said you're going to live without complication if you go on a pump. And we were in this battle with Johnson & Johnson. And at some point we said, what are we doing? It's 15% of the market. I'm worried about that 85% are going to have complications. Let's have a truce, and let's not do that. So we actually, did do some collaboration just to focus on therapy awareness, meaning that this therapy can change lives. Let's focus there. And you grow that pie, we all win. So those kind of conversations, like that, I think will help, especially in the med tech space quite a bit. Thank you.
Thank you so much, Grady. Oh, so exciting. Our next speaker is Sarah Taylor. Sarah is the Vice President and Chief Analytic Officer at Prime Therapeutics, where she establishes strategy for bringing industry-leading analytic insights to Prime's clients in the market. Sarah's focus includes driving client consulting, reporting, health outcomes, predictive analytics associated with integrated pharmacy and medical data, and delivering real-time actionable data and information to plans, providers, and members. Sarah joined the organization in 2020 and has led the data and analytics transformation across Prime in partnership with the data office. Before joining Prime Therapeutics, Sarah led similar centralization efforts and transformation programs for medical health plan within the information technology and finance. Thank you, Sarah.
Thank you. Thank you for having me here today. I decided driving down here that I graduated from this campus 20 years ago, so it's really exciting to be back. Things look a lot different, but the energy on campus, I think, is awesome. But I wanted to share some perspectives on the PBM landscape, really to connect to our business and then the technology and strategy solutions that we drive to support our business. I wanted to open just with a little bit of background on Prime. Like I said, I've spent 20 years on the health plan side, regional health plans. I started pricing at UnitedHealthcare in the early 2000s. And the PBM business, when I joined a year and a half ago, I thought, it's just pharmacy claims. It's going to be so easy compared to where I've been before. And I think the business model is really interesting, and I think Prime has a unique model. So I want to share some background there because it gives context of the type of solutions we're able to drive. So founded in 1998, 2 Blue Cross Blue Shield plans continue to grow to be partner of choice for 23 Blue plans across the country, as well as direct commercial employers. But it has a really unique ownership structure, something very different than what you'll see as we refer to the big 3 PBMs. And I think that's a huge differentiator in the solutions we'll talk about today. Prime's owned by the clients it supports, so there's no shareholders that they're beholden to. And today that's 19 Blue plan owners, 23 clients, and commercial employers. So through this unique relationship, Prime's really able to drive integrated drug management across both pharmacy and the medical benefit. And we'll talk a little bit about why that's really important to the solutions we're driving. And we're headquartered in Eagan, Minnesota. So that's a 32-mile commute for me every day. So a little bit background around Prime's strategy, really focused on redefining integration, really tethered to the quadruple aim outcomes. But this strategy of integration is really founded on that first circle, the integrated data approach. We ingest integrated medical and pharmacy claims across all the populations we manage, something that really made me excited to come to Prime. When you work for large, even the top 40 health plans, their average size is about 600,000 members. So you think about the research data set that Prime's amassed, and it's really exciting to understand the possibility to unlock value. But this also allows us, when we talk about medical and pharmacy, to holistically focus on that patient. Whether their drug was dispensed from a pharmacy or administered in a provider setting, we have that holistic view to be able to kind of actively manage that patient. Some of the other strategies connected to that is channel independence, and that really a lot of this goes back to Prime's ownership structure. Prime doesn't own pharmacy assets, and so they're really in a neutral position to think about kind of the most optimized channel for a patient, whether that be on the pharmacy side or medical side. Prime's also really removed the profit element from the supply chain that we hear about so often. Prime offers full transparency funds flow pass-through to their clients and employers. And that means we pass through 100% of the cost of goods across our supply chain, which is rebates and discounts for drugs at pharmacies. And so together with an integrated member experience, we're really still focused on that triple aim, affordability, member-patient experience, and advanced clinical outcomes. I think Pinar was going to be frustrated if I didn't bring some statistics today. I've kind of operated as a health economist, and I'm sure there's many in the room, and I think we really need to understand kind of the statistics of the landscape we're up against. So specialty is the segment PBMs, plans, employers are really focused on managing, and for good reason. Specialty now comprises 50% of overall drug spend. 34% of that is on the medical benefit, the other half on the pharmacy benefit. And this is concentrated in a really small population. About 2.5% to 5% of patients today of your total population are going to be consuming that specialty spend. And when you think about the total health benefit that we pay for, that includes kind of, physician office visits, hospitalizations, drug spend is nearing 35% of total health spend. And like I said, when I was an underwriter and I started in the early 2000s at UnitedHealthcare, pharmacy was like 10 to 12% of that total total health spend, so significant growth, highlighting kind of the fastest growth rate of any single category, 10% 5-year compound annual growth rate, and this is really where pharma's investing the majority of their dollars. And so these are really positions at headwinds from a unit cost perspective, but I think we all know these are really good things for medicine. We're seeing durable, curable agents in some regards with our biologics, cell and gene therapy pipeline. We have 2 gene therapies today, and I believe 2 more launched. So really emerging advancement in medicine. And so on the positive side, there's also many tailwinds to acknowledge. Biosimilars of 7 reference brands have launched. We're anticipating a launch of Humira, the biggest brand drug that we've ever seen in the industry, will launch biosimilar next year. We're also seeing growing pharma copay dollars that are really helping members reduce their out-of-pocket expense. These are your copay solutions, copay maximizer, and coupons that we can facilitate at point of service. And also the 340B program on the facility side continues to grow measurable value for plans there. And so with kind of this market landscape, Prime's been really focused over the last year to drive a new product innovation arm that's really helping us capitalize on the tailwinds. How do we take advantage of those and deliver that value to our plans and employers? But also kind of understanding where the puck is going, what is your biosimilar strategy, and how are you infusing that into your overall formulary and drug strategy? Okay, and so, I mean, obviously, what does data and technology have to do with all this? I'm sure someone was going to ask. The business solutions that we have to solve for are complex. And in today's competitive environment, my team is positioned to rapidly turn data into information to support the changing needs of our business. And so with that, it's really reinforced to build a modern technology platform that's really managing our data across all of the supply chain, medical and pharmacy included, so that we're positioned to turn data into information. So here kind of really depicts kind of where we've been focused. We launched this platform in June this year, and really starting to capitalize on the investment. But it allows access to the spectrum of use cases across all of our analysts and user community. You think about kind of the analytics and model development that you have. Almost 80% of your time is spent in wrangling data. So how do you create a really optimized structure for analysts to thrive and for us to address a lot of the challenges and support products and solutions? We develop product and solutions, but we also have to model them prospectively. We have to track savings. We have to enter into guarantees, and we have to be really disciplined around how we do that. So we become the backbone and support arm to all of our strategic innovative solutions for our plans. And so just a few perspectives on how we're building that platform and just different use cases that we're bringing to life. A lot of these solutions are just founded on data-driven insights. They really drive all of the product solution strategy that we do at Prime, and it's going to continue to play a bigger role into the future. So we really had to get above that. We've partnered with Google Cloud, kind of leader in cloud computing, introducing cloud-native technologies, everything from our BI platform to AI ML to even statistical modeling tools. And so it's really enabling the use cases that really sit behind all of our products and solutions to prospectively model, to effectively introduce new solutions, and really to just understand that performance across our plans and programs so that we're connecting kind of market landscape, how that's changing, how does that drive your product development pipeline. So together, I think our knowledge platform is really foundational to the product strategy, how we drive, advance, procure insights, and really drive new solutions. One of the best partnerships that I've been a part of at Prime is on a quarterly basis, we do a complete kind of trend evaluation and procure insights around market dynamics, what's going on with lifestyle drugs in Q1, how is our trade strategies and our utilization strategies complementing that, how are we consulting with our plans to address those strategies, and really have this kind of really tight-knit solutioning group that's influencing product, it's influencing recommendations to our plans, and really getting ahead of the curve. So I will pause there.
Questions?
Hi, really nice presentation, thank you. A quick question on the clinical outcomes piece as to how that gets factored into the analysis. And recommend, I think you mentioned that, but I was not sure as to how that works from a patient outcome or from a population analysis standpoint.
So I'll share one use case that I think is really relevant. On some of these complex therapies, we support value-based agreements with pharma, and we're looking to drive outcomes and clinical endpoints that have been articulated in their literature. And so let's call that hospitalizations or discontinuation rate. We track those clinical endpoints. We report back to pharma, and when we achieve those clinical endpoints, the thresholds that we've agreed upon, we're able to push additional rebate dollars to our plans. But building those outcomes is really founded on that integrated medical pharmacy data. A lot of plans use complex grouper logic. Johns Hopkins builds a really nice kind of risk profile and population health profile, as well as symmetry episodes of care help us understand the disease profile and then the outcomes that we see within those disease states. But that's one really good use case. Obviously, a very heavy focus of our plan are our adherence and our interventions around adherence, and then evaluating those programs to make sure that we're getting the results we expect. So I would say there's many use cases for it, but it's following kind of that same paradigm where we're trying to build kind of more of a difference in different study to understand the value of an intervention versus a value of a control group. But it's not dissimilar than how health plans treat that or even provider organizations.
Thank you.
Any other questions, either online or here in the room? Oh.
Thank you. Hi, thank you for the wonderful presentation. And this is also a learning curve for me. So for specialty drugs, I always think of white bagging, brown bagging, clear bagging. Can you give more inputs on that and how Prime Therapeutics thinks about the whole process, and what should we put into policy to help increase patient affordability, accessibility, and definitely the health outcomes? I think we're driving for the gold bagging now, but it's like really hard to push for, but that's like my kind of research topic on that end. Don't know if Prime Therapeutics have any input on that. Thank you.
Yeah, we're looking at a couple of different strategies in that avenue, and this is where do you dispense the drug? Central fill? Do you control the unit cost of that drug in your contracts? Do you align with the, let's just say the hospital, the outpatient setting is administering that drug? We really believe we don't want to disrupt the relationship between provider and patient. And so there's a couple different strategies we've deployed in a product called Integrated RX, where we'll dispense oncology drugs directly from that physician office. That gets drugs to patients sooner, and it can control the waste. You know, we know we're going to have labs on Thursday. Let's dispense 4 days, get our labs, and then reevaluate medication. That's been a very successful program. And then on the infusion side, on the hospital physician home infusion, that's where the question of clear bagging, white bagging, gold bagging comes into play. But it's really important to have those provider partnerships to drive those strategies. But I think the biggest challenge with that is if I'm bringing my drug, it really impacts that patient experience between patient and provider. But definitely a lot of conversation around that right now. I think one of the statistics I didn't present is hospital outpatient average ASP is double than what it is in physician, and very different than procurement of drug directly through central fill pharmacy. So how do you optimize the channel, keep the patient and provider relationship intact, but control for the price of the drug? Because that's where we're really trying to eliminate markup.
All right, thank you, Sarah. What? I'm sorry, I'm so sorry. All right, we have like 1 minute for one more question.
She prepped me, so I don't, this is the.
So I was going to ask is, you must have seen a lot of employers work through their pharmacy spend. So I was wondering if you have any common themes or any ideas of how employers usually manage their pharmacy spend,
I mean,
especially in
those
specialty.
statistics are top of mind for employers. I'll say that. I'm sure Mark's got some perspective there too. Not only pharmacy spend, but if you think about kind of the inflation we'll likely see on the medical side as well, those contracts really lag inflation because they're typically 2 to 3 year contracts. And so there's a lot of headwinds for employers. I know our employer, us, Prime as an employer this year, saw a 5% increase on overall costs. And when we think about inflation over coming years, even on the medical side, which will come through, definitely a lot of challenges. How we're approaching the employer relationship is building really a package solution, because there's a continuum here. There's low managed, well managed, and there's everything in between. And there's reason to make decisions. I want to value access to care, and I want to manage member cost sharing, and I want to potentially kind of narrow my formulary and introduce exclusions to manage that. And so we're building an offering for employers that really is founded on our basic formulary, layering in and really a lot of strategic solutions that we can deploy. The copay solutions are huge to employers. That's probably their number one focus today. But then also retrospective reviews where we're constantly surveilling the benefit to understand where we can optimize dose and convert brand. Those have been really resonating in the employer market. And on a 1-year implementation, we're looking at $10 to $15 PMPM savings for them. So that's about 10%. There's not many things that you can package on the pharmacy benefit to achieve better cost containment, but it requires choice and decisions on how you want to support your employee population, which is very personal to employers.
Thank you.
All right, I know there was a couple other questions online, so I apologize to those folks. Just to kind of keep on schedule here, we're going to take a slightly briefer break. So we'll have 10 minutes, so if we can reconvene back in here at 5:15, that would be good. For those folks who are online, feel free to take a bio break, and we'll get started around 5:15. For those of you in the room, feel free. There are beverages out in the common room next door, so feel free. And there's also restrooms, kind of kitty corner from where we are right now. So we'll see you back here in 10 minutes. Thank you.